can I be the devil's advocate on that one?
Sure.
I was just struck by the very low response rate in the ECOG study as opposed to the HOVON for
Right.
single agent lenalidomide.
Right.
I mean, you're talking about 10% versus 33%, and the 33% is closer to the MDS 002
Right.
and the 005
Right.
study that both looked at. So, I mean,
Right.
explain to me, is this strictly, simply looking at different response criteria?
Well,
or is this
there was
patient
also, there was
selected?
also other information that was interesting about lenalidomide at ASH, and that was SF3B1 mutated patients probably don't respond so well to lenalidomide, or ASXL1 mutated patients, but that it looks like DMNT3A mutated patients may respond. So it may depend on what the mix is.
And I totally
if I may
understand.
answer your
Yeah,
question,
please.
if you don't mind. So there are a couple of things, obviously. Even in the intergroup study, if you look at the responses, the 10% was all comers in the intent to treat. Like if you look at the evaluable patients, it's higher a little bit. Thomas had looked at our experience where he combined data from several centers. In real life, outside the studies, he saw responses, I think, 24, 25%. So that's what we see in real life, single agent lenalidomide.
With non-del5.
Non-del5. So
Okay.
in this study, there are two things. First, the criteria are not the IWG-26. They are the older criteria, and they were modified to be even more strict. So if you achieve the transfusion independence, you have to have a
another
hemoglobin
gram.
increase.
Yes.
More than a gram and a half. So they were more than the usual criteria. So it was, it was a much more strict criteria than the usual. If you could go, and I'm sure we will see the follow-up later on, publishing the data as ad hoc by the IWG-206, it's going to be higher. The other point is in the intergroup study, there were patients that were treated by hypomethylating agents. And that had not been the experience in neither of the original MDS 002 or 05 that looked at the non-deletion 5q, neither the HOVON study. Because in Europe, you don't have access to azacitidine in lower risk.
Yeah.
So we've done, and we are presenting at this meeting, data on the sequence of those therapies in lower risk MDS, and does it matter? And the rationale for that, we wanted to look, is most of those studies that did LEN, there were no azacitidine exposure. So we asked the question, does it matter? Because the NCCN guidelines actually don't put a preference. They just say LEN and hypomethylators are options for lower risk. So it turned out in our experience, if patients were just anemic, again, if patients have thrombocytopenia, then obviously you are going to go for hypomethylating agents. If we are treating anemia particularly, that basically, sequence probably matters. And in our experience, the response rate to LEN as a first-line therapy is in the range of 20% or so. If you did it as second line after azacitidine, it was 10%. So that explains part of what we're seeing in the study. When you look at hypomethylating agents, whether they were done first line or second line, there was no difference in the responses. They were in the range of 30%. When you look at survival and leukemia, doesn't seem that the sequence matters, but the responses do. So in my mind, a strict criteria and patients treated with hypomethylators on the intergroup study could explain the difference.
So that will be probably one of the big challenges we'll have to face in the next years, to clearly have a strategy and some decision-making algorithm to know what kind of therapy for low-risk patients will go as a second-line treatment.
Yeah, I think we should also, the point you brought up is important. We may identify certain genomic factors that predict response to lenalidomide. Right. But I just want to come back to this. So for a clinician who's treating a patient with lenalidomide, what is the expectation? Do they expect improvement in hemoglobin? When do you call somebody failure of lenalidomide?
Also, if you're talking about deletion 5?
I'm talking about non-deletion 5.
Non-del5, okay.
Because commonly patients are started on the drug, right? But then what is the expectation and when do you change?
I think we also have to face a little bit like what we have for non-deletion therapy, the issue of side effect and early discontinuation. Right. And we saw from time to time patients coming from the community who just have 1 month of lenalidomide for non-del5q, and that probably not really failure of the therapy. Based on the clinical trial, most of the patients were in clinical trial exposed for 6 months. It's maybe kind of long, so I think most of the centers consider 3 to 4 months before considering failure or not of the therapy, and thinking about any other option in that case. Yeah, so I think for 4 months, 3 to 4 months.
Yeah, I think that's exactly what the study showed. I mean, for the response assessment, it was done at 6 months, but most of the people who responded did so by
Correct.
the end of the fourth.
I think in terms of what you are looking at, obviously you are looking at hematological improvement.
Yes.
In deletion 5q, the responses are very high,
Right.
and this is less. But like you are looking at patients becoming transfusion
Right.
independent, hemoglobin going up. Even sometimes some transfusion reduction could be meaningful for the patient. But after 4 months, as Toma mentioned, if it's not there, then I don't think there is a value to continue treatment.
No.
But you are not looking at modifying the disease in the non-deletion 5q.
That's always been the
Right.
challenge, right?
Right.
How do
Yeah.
you know if the survival is impacted? The only thing you can really look at is the transfusion.
Well, on the non-del5q population, I don't think there's any data showing any improvement or survival
Right.
by the in an untreated population.
Neither it
Responders
has
may
been-
have a benefit, but
So what you're saying is give it for a good
4 months.
4 months, and if there is no improvement in hemoglobin, then we call
Right.
that a failure.
Right.
Call it a day.